So, what if I told you that for decades, the very machines designed to save dying patients in the intensive care unit were like actually the things killing them?
I mean, it's a terrifying realization, and
Oh.
grappling with that fact, it completely changed the way modern critical care medicine is practiced today.
Yeah, it really did. So, welcome to today's deep dive. We are taking you straight into the ICU to look at a medical emergency that historically carries just this massive mortality rate, up to 45% in its most severe form.
Right, which is huge.
Totally. We are talking about ARDS, or Acute Respiratory Distress Syndrome. And, if you lived through the COVID-19 pandemic, you probably heard this acronym thrown around a lot on the news.
Yeah, it basically became a household word overnight.
Exactly. It became synonymous with like ventilator shortages and images of patients being flipped over onto their stomachs. But looking through the stack of medical research, nursing textbooks, and clinical trial data we've gathered for you today, it becomes incredibly clear that ARDS is way older and, well, much more complex than just one virus.
Ah,
So, our mission today is to figure out exactly what happens when the lungs suddenly fill and stiffen. We're going to explore the bizarre origins of this condition, the counterintuitive ways doctors have learned to treat it, and the humbling failures that forced the medical community to essentially rip up their own textbooks and just start over.
it's a wild history.
Yeah.
And to really understand the stakes here, we first have to discard a very common assumption. Because when a patient's lungs are failing and they can't get enough oxygen, the immediate thought is usually, oh, they have a terrible infection.
Right, which is totally where my brain went. Going into these sources, I just assumed ARDS was the technical doctor speak term for like super severe pneumonia.
Most people do. I mean, even some healthcare professionals can conflate the two early in their training because pneumonia is a specific infection of lungs caused by a bacteria or a virus or a fungus.
But ARDS isn't that.
No, ARDS is not an infection. It doesn't require any specific pathogen at all, actually. In medicine, we refer to ARDS as a final common pathway.
A final common pathway. So it's a destination, not the journey.
Exactly.
The analogy I kept writing in the margins of our notes is that ARDS is basically the human body's equivalent of a check engine light.
Oh, that's a good way to look at it.
Yeah, like when that light flashes on your dashboard, it tells you the car is breaking down, but it tells you absolutely nothing about the underlying cause. It could be a blown head gasket, it could be bad fuel, a shredded belt, whatever.
Right, the light just means disaster is happening.
Exactly. And looking at the list of triggers for ARDS in the literature, it's a crazy variety of things. I mean, obviously, a severe pneumonia can trigger it, but so can sepsis, blunt physical trauma from a car crash, acute pancreatitis, massive blood transfusions, or, and this sounds awful, even a patient accidentally inhaling their own stomach acid.
Yeah, aspiration is a major one. And what unites a car crash and, say, a pancreas problem is the systemic response.
The inflammation, right.
Exactly. The body sustains a massive insult and mounts this overwhelming systemic inflammatory response to try and survive. And the lungs just happen to become the most visible casualties of that crossfire. We actually define ARDS purely by observing that specific damage.
Okay, so how do they define it at the bedside?
The current standard is called the Berlin definition, which was finalized in 2012. And it requires three things to happen simultaneously. First, the timing has to be acute, meaning the respiratory failure sets in rapidly, usually within 1 week of the known clinical insult.
Okay, so it happens fast.
Very fast.
Then,
Then there's the visual component.
right, the sources talk about the chest x-ray looking like a whiteout.
Yeah, because healthy lungs are full of air, and air shows up as black on a standard x-ray.
Mhm.
But when a physician looks at an x-ray of an ARDS patient, both sides of the lungs look clouded, hazy, or just completely opaque. They are white.
Wow. And the third thing.
The third criterion is hypoxemia, which is dangerously low oxygen in the blood. We measure this with something called the PF ratio.
Okay, I saw that PF ratio mentioned everywhere in the reading. Can we like translate that into plain English for a second?
Sure, it is the ratio of arterial oxygen compared to inspired oxygen.
Okay, so arterial is what's in the blood.
Right, arterial oxygen is how much oxygen is actually making it into your bloodstream. And inspired oxygen is the percentage of oxygen the ventilator is pushing into your lungs.
Oh, I see.
So if the machine is pushing 100% pure oxygen down your airway, but your blood oxygen levels are still just plummeting, your ratio is terrible. But notice what is entirely absent from that diagnostic criteria.
Yeah, there's no biopsy, there's no blood test for a specific, I don't know, ARDS gene or bacteria. It's just Did it happen fast? Do the lungs look cloudy? And is the oxygen low?
Exactly. And we only figured this out because of a massive conceptual leap back in 1967.
Oh, right, the origin story.
Yeah, a thoracic surgeon named David Ashbaugh and a physician named Thomas Petty published this landmark paper in The Lancet. And they analyzed a tiny cohort, just 12 patients.
Wow, just 12.
Just 12. And these patients had entirely different original injuries. Some had trauma, some had viral infections, some had pancreatitis, yet they all developed the exact same stiff, hard-to-ventilate lungs.
That's fascinating.
Ashbaugh and Petty were the first to recognize that this was a distinct, unifying clinical syndrome.
And they originally named it Adult Respiratory Distress Syndrome.
They did, yeah. They wanted to differentiate it from infant respiratory distress syndrome, which is a condition seen in premature babies whose tiny lungs simply haven't fully developed yet.
Right, a developmental issue, not an injury.
Exactly. But the adult label caused confusion almost immediately because children and toddlers who suffer severe trauma or sepsis can absolutely develop this exact same inflammatory lung failure.
So they changed it.
Yeah, over the decades, the medical community quietly swapped out the A, changing it to Acute Respiratory Distress Syndrome.
Okay, so if ARDS is this final common pathway triggered by massive inflammation, we really need to talk about what is physically breaking down in the chest. Like, when we say the lungs fill and stiffen, what is the actual anatomy of this collapse?
Well, we can break the collapse down into 3 failing layers. Layer 1 is the destruction of the alveolar capillary barrier.
Let's zoom way in on that. What does that barrier normally do?
So every time you take a breath, air travels down your windpipe and into millions of microscopic balloon-like sacs called alveoli.
The air sacs.
Right. And wrapped tightly around every single one of those tiny air sacs is a network of microscopic blood vessels, or capillaries. For oxygen to get from the air inside the balloon into your bloodstream, it has to physically cross the barrier between the sac and the blood vessel.
Okay, that makes sense.
And in a healthy person, that barrier is incredibly thin, about half a micrometer.
That's like less than the width of a single cell, isn't it?
It is. It has to be thin for the gas molecules to diffuse across it quickly. But when that massive systemic inflammatory cascade hits the lungs, it just attacks that delicate barrier.
Oh, wow.
The cells lining the air sacs and the cells lining the blood vessels become severely injured. The barrier breaks down and becomes highly porous.
This is where a plumbing analogy really helped me visualize it.
Yeah.
Because in standard heart failure, fluid backs up into the lungs because the heart, which is the pump, is failing to push the blood forward.
Right, the pressure builds up.
Yeah. But the medical term used in these sources for ARDS is non-cardiogenic pulmonary edema, which basically means the pump is fine.
The heart is doing its job perfectly.
Exactly. The issue is that the microscopic pipes themselves have turned into Swiss cheese.
Yes, the pipes are heavily damaged. And because they are so porous, they begin leaking a thick, protein-rich fluid straight into the air sacs. The alveoli literally fled from the inside out.
Oh, which leads to the second failure layer I saw mentioned, surfactant. What is surfactant, and why does this fluid wipe it out?
So, surfactant is a vital, sort of soapy substance produced by specialized cells in your lungs. And its entire job is to lower surface tension. Have you ever tried to blow up a balloon that was completely wet on the inside?
Oh, yeah. The sides just stick together. It's almost impossible to force the air in to pop it open.
That is surface tension. Surfactant acts like a lubricant to prevent the walls of your microscopic air sacs from sticking together, keeping them propped open at the end of every breath.
Okay, got it.
But that protein-rich fluid flooding in from the damaged blood vessels is highly toxic to the cells that produce surfactant. The cells die off. Yeah. And without surfactant, those tiny wet air sacs just collapse flat. We call this atelectasis.
So if the air sacs are collapsed flat and filled with this protein sludge, no air is getting in there.
None at all. Gas exchange becomes physically impossible in those areas, and this creates a critical medical problem known as a shunt.
A shunt.
Yeah. The right side of your heart pumps dark, deoxygenated blood through the lungs, expecting it to pick up oxygen. But because so many air sacs are collapsed, the blood just shunts right past them. It travels back to the left side of the heart without ever touching a molecule of oxygen.
Wow. This completely explains why maxing out the ventilator doesn't work. I was reading this thinking, if a patient's oxygen is low, just put a mask on them and blast them with 100% pure oxygen.
It seems like the logical fix.
But if there's a shunt, you could pump all the oxygen in the world into their windpipe and it wouldn't matter. The bridge is just out, the gas cannot reach the blood.
Exactly. The oxygen just hits a dead end. And this inflammatory destruction follows a very specific, devastating timeline, which leads to the third layer of failure, the scarring.
The fibrotic phase.
Right. Pathologists divide ARDS into 3 overlapping phases. The first few days make up the exudative phase. That's the acute injury, the leaky pipes, the flooding we just talked about.
What happens if they actually survive that initial flooding? Does the fluid just slowly drain away?
Well, the body attempts to fix the damage. Entering roughly week 2 or 3, the lung moves into the proliferative phase. The tissue starts frantically multiplying cells to patch those Swiss cheese holes in the barrier.
Sounds like a good thing.
It can be. In a lucky patient, the inflammation dies down and the lung begins to heal. But if the inflammatory cycle doesn't break, the patient crosses a terrifying threshold into the fibrotic phase.
And this is where those delicate half-micrometer air sacs are replaced by thick scar tissue.
Yes. The lung physically transforms from a spongy elastic organ into something stiff and hard. And once the lungs remodel into dense scar tissue, the damage is largely permanent. The patient loses lung capacity forever, assuming they survive at all.
That is brutal. So put yourself in the shoes of an ICU doctor decades ago. You have a patient whose lungs are stiffening, their air sacs are flooded, they're visibly suffocating. My immediate, total layperson instinct is force the lungs open, turn the ventilator up, crank the pressure, and just push a massive volume of air into their chest to pop those wet balloons open.
And that was the intuitive, unquestioned instinct of the entire medical establishment for over 30 years.
Really?
Oh, yeah. Which brings us to the paradox of treatment. The most monumental breakthroughs in ARDS survival came from the horrifying realization that our instinct to help was actually actively killing people.
Wait, hold on. You're telling me a patient is actively suffocating in front of the medical team, and the breakthrough was deciding to give them less air. How did any ethics board even approve testing that?
Because the data was starting to show that the mechanical ventilators were causing massive collateral damage.
Yeah.
Think about the physics of a stiff, fluid-filled lung. In a severe ARDS patient, maybe 70% of their lung tissue is collapsed and consolidated.
Okay.
So only 30% of the lung is still healthy and capable of receiving air. We call this the baby lung concept.
Oh, because the functional part of the adult's lung has literally shrunk down to the size of a baby's lung.
Precisely. Now imagine taking a normal, deep adult breath, say 12 milliliters of air per kilogram of body weight, and forcing all of that volume into a lung that only has 30% of its normal capacity.
Oh, God.
Right. The heavy diseased parts of the lung won't open, so the air takes the path of least resistance.
So all that massive volume of air gets forced into the tiny remaining fraction of healthy tissue.
Yes. It violently overinflates the healthy alveoli. It stretches them to their absolute physical limits with every single breath, thousands of times a day.
That sounds like torture for the lungs.
It creates sheer physical trauma, literally ripping the fragile lung tissue apart from the inside. We were creating a secondary disease called ventilator-induced lung injury, or VILI.
And this is where the landmark ARMA trial comes in, right? The one often referred to as the ARDS-NET trial from the year 2000.
Yes, it is arguably the most important clinical trial in the history of critical care. The investigators decided to test a radical idea. What if we turned the volume on the ventilator way down?
Like how far down?
Instead of the standard 12 milliliters per kilogram, they gave the patients just 6 milliliters. Tiny, shallow, gentle breaths.
And the results were so lopsided, they actually had to halt the trial early, didn't they?
They did. The patients receiving the traditional large breaths had a mortality rate hovering near 40%. But the patients getting the small, gentle breaths saw their mortality drop to about 31%.
That is incredible.
Simply turning a dial on a machine to deliver less air-reduced deaths by almost a third.
But logically, I mean, taking tiny, shallow breaths creates a whole new problem. If you barely breathe, you can't exhale enough carbon dioxide. Doesn't the CO2 level in the blood just skyrocket?
It spikes significantly. And carbon dioxide isn't just an inert waste gas. It binds with water in the blood to create carbonic acid. So high CO2 makes the patient's blood dangerously acidic.
So how is that an acceptable trade-off? Acidic blood sounds like something an ICU doctor would want to fix immediately.
It requires a massive psychological shift for the physician. It relies on a concept called permissive hypercapnia.
Permissive hypercapnia.
Yeah. Permissive meaning giving permission. Hypercapnia meaning high carbon dioxide. Modern critical care teams will deliberately let a patient's CO2 levels rise and they will tolerate blood oxygen levels that are uncomfortably low.
They just let the alarms ring.
Basically, they stare at those ugly flashing red numbers on the patient monitor and they sit on their hands. They accept the acidic blood because they know that cranking up the ventilator to fix the numbers will physically shred whatever healthy lung tissue the patient has left.
It's just an incredible display of restraint, doing less to save more. And that restraint extends to another massive breakthrough we found in the research, the Perseva trial in 2013, led by Claude Guérin.
Proning. It is one of the most elegant, low-tech interventions in all of medicine.
And proning is just the medical term for physically flipping the patient over onto their stomach, which, sounds simple until you picture a comatose patient hooked up to a ventilator, central lines, feeding tubes, and monitors.
It takes a lot of coordination.
I bet. It must take an entire team of nurses and respiratory therapists to carefully roll them over without pulling out a life-saving tube.
It does. But the Perseva trial took patients with severe ARDS and proned them for at least 16 hours a day. And the results were staggering. The mortality rate for patients left on their backs was roughly 33%.
Okay.
But for the patients flipped onto their stomachs, mortality was cut in half, down to 16%.
Cut in half. From a purely mechanical, gravity-based intervention, like no million-dollar experimental drug, changing the patient's physical position in space, how does gravity even do that?
Well, think about the anatomy of the chest. The heart is a dense, heavy muscle sitting right in the front of the chest cavity. When a patient lies supine on their back, that heavy heart sits directly on top of the lungs.
Okay, that makes sense.
Furthermore, the fluid leaking into the lungs is heavy, so gravity pulls that inflammatory sludge down to the back of the lungs, squishing all the tissue against the spine.
So the back of the lung is getting crushed by fluid, and the front of the lung is getting crushed by the heart.
Exactly. But when you prone, the patient flip them onto their stomach gravity works in our favor. The weight of the heart falls onto the breastbone, taking the pressure off the lungs.
Oh, wow.
And the fluid slowly redistributes. So all of that undamaged, healthy tissue in the back of the lungs suddenly opens up, allowing those tiny, gentle breaths from the ventilator to actually reach the blood.
It's pure physics. So reading through all this, lowering the tidal volumes, accepting higher CO2, flipping patients on their stomachs, it genuinely feels like the medical community just cracked the code.
It is tempting to view it as a solved puzzle, but this is where we have to pivot into the deeply humbling reality of critical care.
Oh.
Yeah, while we've celebrated these mechanical triumphs, the history of ARDS is also littered with physiologically perfect theories that failed disastrously in the real world.
Let's talk about those cautionary tales. High-frequency oscillatory ventilation, or HFOV, is a prime example from the sources. The logic behind this makes total sense to a layperson.
It really does.
Like, if small breaths are good because they don't stretch the lung, shouldn't hundreds of tiny vibrating breaths be even better? Why not just vibrate the air in and out, keeping the lung perfectly still so it never stretches at all?
On paper, it was a beautiful theory. It sounded like the ultimate high-tech solution to ventilator-induced lung injury. So researchers launched the Oscillate trial in 2013 to test these high-frequency oscillators in adults with moderate to severe ARDS.
And what happened?
The trial was halted prematurely by the Safety Monitoring Board.
Because the vibrating ventilators weren't helping.
Because they were actively causing harm. Patients on the high-frequency oscillators were dying at a higher rate than those receiving the standard low-volume gentle breaths.
Wow, that's tragic.
It is, and it serves as a stark, permanent reminder for every medical professional. Mechanistic reasoning must always yield to randomized clinical trials. You can have a theory where the physics are flawless, but you simply do not know how a complex biological organism will react until you test it.
And we saw the exact same humbling reversal with the practice of paralyzing patients, right? The sources outline this massive flip-flop over neuromuscular blockades.
Yeah. So in 2010, a major trial called Acute Respiratory suggested that administering paralytic drugs to severe ARDS patients for 48 hours improved survival. The rationale was that if the patient is paralyzed, they can't fight the ventilator.
That makes sense.
Right? Their breathing muscles relax, allowing the machine to deliver those gentle breaths perfectly, letting the lungs rest.
And the result was that intensive care units everywhere started routinely paralyzing their severe ARDS patients. It basically became the standard of care.
Entire protocols are rewritten, but science is an iterative process. 9 years later, the ROSE trial was published in 2019. It was a larger, rigorous study looking at that exact same paralysis strategy, and it
Yeah.
found absolute zero mortality benefit.
Oh man, so the ICUs had to sheepishly walk the whole practice back?
Basically, yes. It proves that critical care is inherently unpredictable. Even practice-changing trials sometimes fail to hold up when replicated on a larger scale or applied to slightly different patient populations.
Which brings us to the biggest illusion of all, the very definition of ARDS itself. We started this deep dive talking about the 2012 Berlin definition, the clinical criteria, acute timing, the X-ray whiteout, the terrible PF ratio indicating low oxygen.
The rules we use to diagnose the syndrome at the bedside.
Right. But there is a shocking autopsy study done in 2013 by a researcher named Phil. The researchers looked at the lungs of patients who died in the ICU after meeting all those strict clinical criteria for ARDS.
And the findings shake the very foundation of how we view this disease.
They really do.
When they examined the lung tissue of those patients under a microscope post-mortem, only about half of them actually had the textbook cellular pathology, the diffuse alveolar damage, or DAD, that we associate with ARDS.
Only half. That means 50% of the time, a doctor is standing at the bedside looking at a clouded X-ray and a low oxygen number on a monitor, diagnosing ARDS and initiating all these complex protocols. But on a microscopic cellular level, something entirely different is destroying that patient's lungs.
Exactly. It highlights a massive vulnerability in critical care. Our well-validated definitions are still just imperfect proxies for biology. We are categorizing people based on how they look on an X-ray and how their lungs interact with a mechanical pump, rather than treating their underlying cellular disease.
And nothing exposed the cracks in our medical frameworks quite like COVID-19. Almost overnight in 2020, SARS-CoV-2 flooded ICUs globally. It became the largest single driver of ARDS cases the world had ever seen simultaneously.
The sheer volume of patients immediately reignited all of these historical debates. An Italian intensivist named Luciano Gattinoni observed his COVID patients and proposed that their lungs were behaving completely differently than textbook ARDs.
Yeah, he suggested there were two distinct phenotypes, right? An L type where the lungs were highly compliant and stretchy, and a traditional H type that was stiff.
He was sounding the alarm that treating all these COVID patients with our rigid, one-size-fits-all ARDS protocols might be the wrong move.
Did it change things?
It sparked a fierce international debate. Later physiologic studies ultimately showed that, for the most part, COVID ARDS lungs did behave similarly to typical ARDS lungs. But the pandemic proved how a novel disease can utterly stress test our established medical paradigms.
It also revived the war over steroids, didn't it?
It definitely did.
Yeah.
The 2020 recovery trial demonstrated a clear survival benefit from using dexamethasone, which is a cheap, readily available steroid, in COVID-19 patients who required oxygen.
And that brought up old arguments.
Huge arguments. That single finding revived a decades-old, incredibly heated debate about whether we should be using steroids to suppress the immune system in non-COVID ARDS patients, a topic that remains fiercely debated in medical journals today. We just don't have all the answers.
We have covered a massive amount of ground today. Let's quickly synthesize the journey you've been on with us. We established that ARDS is a devastating syndrome, not a single disease. It is a leaky capillary problem, not a failing heart problem.
The inflammatory cascade turns the microscopic pipes to Swiss cheese, wiping out surfactant and collapsing the air sacs.
And the entire history of treating this condition over the last 50 years has been a story of learning how to be gentle. We learned to lower the tidal volumes on the ventilator to stop tearing the lungs apart, even if it makes the blood acidic.
Right.
We learned the profound gravity-driven power of flipping patients onto their stomachs.
We also learned to be highly judicious with IV fluids, keeping patients relatively dry, as demonstrated in trials like FACT-TT, to prevent even more fluid from leaking into those damaged airspaces.
For anyone listening who works in healthcare or just wants to understand the human body, these aren't just obscure lessons for infectious disease wards. These core principles, protecting the lung from physical trauma, not overventilating, considering the physics of positioning, they apply to car crash victims, obstetric emergencies, and routine surgical complications.
They really are the bedrock of acute care medicine, because the final common pathway respects no single disease.
I want to leave you with a final thought to mull over. We mentioned that Phil autopsy study, the revelation that our bedside clinical definition of ARDS only matches the true cellular pathology half the time.
It raises a profound and slightly unsettling question about the future of critical care medicine.
What if we have been looking at this from the wrong angle for half a century? What if, in the near future, we stop lumping patients into broad categories based purely on how their lungs look on a chest x-ray or how they react to a ventilator?
It's a paradigm shift.
Exactly. What if medical science finally figures out how to look past the flashing check engine light and starts treating the specific, unique biological fingerprint of the inflammation driving the destruction?
If we can crack that cellular code, the intensive care unit of tomorrow will look vastly different and save vastly more lives than the ICU of today.
Until that day comes, the monitors will keep beeping and the medical teams will keep fighting for every single breath.